Welcome back to the deep dive. Today, we are strapping on the surgical loops and stepping deep into the intellectual architecture of modern vascular surgery.
hmm
We are not here for basic textbook definitions. We are taking the MCH level playbook, the master strategy used by surgeons when a life and critically a limb hangs in the balance.
That's absolutely right. The source material we've gathered is, it's essentially a complex, high-stakes decision algorithm.
Right.
We are focusing intensely on peripheral arterial disease management, specifically its most devastating manifestation, chronic limb thread ischemia, or CLTI.
And this is about so much more than just clearing a blockage, isn't it?
Oh, absolutely. It's about a highly strategic, customized plan for limb salvage dictated by, these really complex anatomical and clinical variables.
Our mission today, then, is to sort of demystify this advanced decision-making process for you. We want to understand the strategic thinking, the intricate why behind the choices that vascular surgeons make.
Right. The choices they make when they're trying to save a limb from amputation. If you listen closely, you'll really grasp the level of nuance required to manage these patients.
And I think there's a core philosophy here.
There is.
Yeah.
And if we could boil the entire thing down, it comes back to one fundamental, non-negotiable dual goal.
Okay.
PAD management is, and it must always be considered, a cardiovascular survival intervention and a limb preservation strategy.
So you can't have one without the other.
You fail the patient if you do. The heart and the leg are completely inseparable here.
Okay, let's unpack that. Let's start by defining the severity, because before a surgeon even thinks about a scalpel or a catheter, they have to, map out the entire problem.
Precisely. You have to map it out. You can't capture the stakes involved with just a single metric. So to properly triage these high-risk patients and predict their prognosis.
Both short-term and long-term.
Exactly. And the long-term durability of the repair. Surgeons use a combination of three distinct classification systems. It gives them like a three-dimensional map of the problem.
A 3D map. Okay, so let's walk through those three lenses. What's the first one? The one that tells a surgeon, how fast do I need to move?
That would be the WIFI classification.
EYFI.
WIFI. It stands for wound, ischemia, and foot infection. This is your clinical urgency metric. It tells you how immediate the threat is to the limb tissue itself.
So it's breaking down the immediate danger.
The wound component is graded by size and depth. Ischemia is graded by, rest pain or lack of perfusion. And foot infection, of course, that defines the risk of sepsis.
So WIFI is really the clinical clock ticking. A high WIFI score, you're in the emergency zone.
You are. A patient with WIFI-4, that's extensive tissue loss, and a high infection score, you are already in emergency territory.
But like you said, that score doesn't tell you how difficult the actual repair will be.
It doesn't. Not at all. You could have a patient with a massive infection, so a high WIFI, but the blockages that caused it are actually pretty simple.
I see.
And conversely, you could have a small wound, a low WIFI, sitting on top of diffuse, rock-hard multi-segment disease.
So for the technical difficulty, you need another tool.
You do. To map that technical difficulty, we turn to the GLAS system. That's the Global Limb Anatomic Staging System.
GLAS. And that's all about the plumbing itself, right? The anatomy.
Purely the anatomy. It grades the lesions based on severity, length, location, and crucially, calcification. A simple focal stenosis gets a low GLAS score.
And a really bad one.
A long segment, heavily calcified, multi-level occlusion, say, a blockage spanning the entire thigh and knee gets a high score. And that means a much more difficult procedure and, often lower long-term success.
So we have timing from WIFI, technical challenge from GLAS. What's the third piece? You see that's a bit more of a classic one.
That's the Rutherford classification. This is a really well-established scale that just defines the clinical symptoms of the ischemia.
How does that work?
It ranges from grade 1, which is mild claudication pain on walking, all the way up to grade 6, which is major tissue loss or gangrene. It just offers a broader, universally understood staging of the disease.
I see. So the whole point of using all three, Rutherford, WIFI, and GLAS, it's not just for a diagnosis, is it? It's for planning.
It is precise prognosis and intervention planning. When you combine those scores, the patient immediately falls into one of three distinct outcome groups.
Yeah.
And that defines the entire strategic challenge ahead.
Okay, what's the first group, the lowest tier?
That's lifestyle-limiting claudication. These patients, they feel pain when they walk, but they don't have any immediate tissue loss or rest pain. So the goal here is usually conservative.
And the middle group, this is where it gets serious.
This is the chronic limb thread ischemia CLTI group, the heart of the matter for us today. These are your Rutherford stages 4, 5, and 6, often with high WIFI scores,
So these are the patients with rest pain, non-healing wounds.
or frank tissue loss,
Yeah.
meaning without intervention, they are looking at a major amputation, and probably within a pretty short period. This is our target for aggressive revascularization.
And then there's the final, and I guess the most difficult group.
The no-option limb. And this is where the GLAS score is just so high or the patient's overall health is so poor that reconstruction is either technically impossible,
Just no road left to fix.
no road left,
Yep.
or it's just deemed medically futile. So the focus then shifts from salvage to necessary amputation and pain management. Understanding these tiers is the foundation for everything we're about to explore.
That sets the stage beautifully. Okay, let's pivot now to section 1, which is all about that conservative and systemic optimization. And this brings us right back to that duality survival and limb.
It does. And the philosophy here is really captured in this, what the sources call a MCH-worthy line.
What's the line?
Optimizing inflow is incomplete if the heart and brain remain at risk.
Wow. Okay, that's powerful.
It's critical because it forces every clinician to see PAD not as this isolated plumbing problem in the leg,
Right.
but as a dire manifestation of systemic generalized atherosclerosis.
That completely shifts the priorities, doesn't it? I mean, if I save the limb, a huge surgical win, but the patient has a fatal heart attack 6 months later, the whole thing is a failure.
Exactly. The core belief is that limb preservation is secondary to overall cardiovascular survival.
Yeah.
When we see PAD, we know that patient has disease in their coronaries, their carotids.
It's everywhere.
It's everywhere. So our treatments have to aggressively prioritize reducing that cardiac and stroke risk. And that means a level of pharmacological management that is, well, it's intense, it's aggressive, and it's lifelong.
Let's get into those specifics. Where does that aggressive management start? What's the cornerstone?
The cornerstone is, without a doubt, statins. And we're moving way beyond just looking at an LDL cholesterol number here.
So what's the real goal with statins in PAD?
In PAD, statins are crucial because they stabilize the existing plaque, making it less likely to rupture and cause an acute event. And over time, they can even lead to some plaque regression.
So it's about stability.
Stability and survival. This aggressive high-dose statin use, it directly translates to reduced future cardiovascular events. It's non-negotiable, lifelong therapy.
And alongside that, you have to get a handle on all the underlying metabolic problems.
You have to demand highly controlled management. There's just no wiggle room. For patients with CLTI, especially diabetics, their glycemic control has to be meticulous.
Why is that so critical for the limb itself?
Because high fluctuating blood sugar, it just accelerates microvascular damage and neuropathy. So wounds won't heal, and worse, they won't even feel the injuries that lead to these devastating infections.
Okay, so tight control of blood sugar, blood pressure, lipids.
All of it. Stringent management to slow the progression of the systemic disease that put them on the operating table in the first place.
So once we've managed that systemic risk, how do we protect the actual fix the stent or the bypass?
That brings us to dual antiplatelet therapy, or DAPT. Right. So single antiplatelet therapy, like aspirin, is standard for all PE patients. But DAPT combining two agents, like aspirin and clopidogrel, becomes essential, especially after an intervention.
So this is to stop the new plumbing from clotting off.
Instantly, yeah. Whether we've placed a stent or done a bypass, DAPT helps maintain patency and prevents the formation of thrombus, of clots that could just destroy the revascularization. It's a critical part of preventing recurrence.
It sounds like the patient has to be incredibly compliant with a very complex drug regimen for life.
Absolutely. The patient's commitment to their medical management is, it's just as important as the surgical success itself.
Okay, now let's look at the first-line treatment for those who aren't yet in that CLTI danger zone. The patients with just lifestyle-limiting claudication. The main recommendation here seems almost paradoxical. It's exercise.
It is the great counterintuitive success story of PDA management, and it has the strongest recommendation in all the guidelines: supervised exercise therapy, or SET.
And that's a Class IA recommendation, the highest level of evidence.
The highest.
So the paradox is you're telling a patient whose legs hurt when they walk to walk more.
Yes, to walk through the pain.
So why is that short-term pain necessary for the long-term gain? What's happening in the body?
We are leveraging the body's adaptive response to oxygen deprivation. When you force that muscle to work beyond the point of pain, beyond claudication, it signals a desperate need for oxygen.
And that stress causes changes.
Two critical, powerful changes. First, the muscles become drastically more efficient at using what little oxygen they get. That's mostly through mitochondrial changes.
Okay, so they learn to be more efficient.
And second, and this is the most important part, the hypoxia, the lack of oxygen, activates growth factors and signaling pathways that drive collateral circulation.
Ah, so you're forcing the body to build its own natural bypasses?
Precisely. You're forcing these tiny pre-existing vessels that normally carry very little blood to grow larger, to become more numerous, and to establish functional pathways around the main blockages.
It's literally biological revascularization.
It is. And studies consistently show that rigorous ESET can significantly improve walking distance and quality of life.
Yeah.
Sometimes it can even delay or eliminate the need for an invasive procedure altogether. It just shows the body's resilience.
That aggressive medical management is the foundation. So now let's leave the pharmacy behind and enter the strategic heart of this deep dive, the operating room. The planning here is governed by a very strict three-step rule.
This rule is the blueprint. It ensures you don't waste time on a downstream problem when the upstream pressure is no good. The progression is always ISS inflow first, then the femoral popliteal conduit, and finally the tibial runoff.
Inflow, conduit, runoff. Why is that order so sacred?
Because pressure dictates flow. It's basic physics. Inflow is the blood supply from the aorta down into the iliac arteries, the main pipes in the pelvis.
Right.
If you have a blockage there, your pressure down the whole leg is poor, no matter how clean the arteries in your thigh or foot are. You have to fix the biggest blockage first to maximize the pressure head.
So if you fix the foot first, it's just going to fail.
Quickly, because it lacks the driving pressure from above.
So once that iliac inflow is assessed and it's diseased, what's the standard strategy for those big vessels?
Iliac lesions are almost always endovascular first. It's a strong Class IA recommendation.
Why is that?
Because the iliacs are large, they're retroperitoneal, relatively fixed vessels. We can get phenomenal, durable results with minimal risk just using wires and stents.
And the open surgery alternative is much riskier.
Exponentially higher risk. An open aorta bifemoral bypass is a huge operation. So the minimally invasive endovascular route is the default choice unless the anatomy is just extremely complex.
Okay, let's move down the leg to that femoropopliteal conduit. This is where endovascular has really changed the game, hasn't it?
It's revolutionized this segment. The tech, smaller catheters, better wires, specialized devices, has made it possible to address long, complex lesions with much less trauma.
But you have to be careful here, right? This part of the leg moves a lot.
A lot. The SFA, in particular, moves with the knee joint, which leads to higher rates of failure. So we have to choose our weapons very carefully.
Okay, let's break down that toolkit. For a simple focal lesion, you start with the simplest tool.
That's standard balloon angioplasty. You just inflate a balloon, crack the plaque, and open the vessel. It's effective for short, non-calcified stenosis.
But the vessel can just spring back, recoil.
It does. It recoils, or the inner lining proliferates back into the vessel. That's called restenosis.
And to combat that biological response.
We use the drug-coated balloon, or DCB. The major failure mechanism here is neo-intimal hyperplasia, this overgrowth of smooth muscle cells into the vessel after the injury from the balloon.
So the drug stops that from happening.
The DCB, once it's inflated, delivers an anti-proliferative drug, usually paclitaxel, right into the vessel wall to inhibit that regrowth. And the benefit is huge. It leads to dramatically superior patency compared to plain balloons. It's the workhorse for SFA lesions.
And if the balloon causes a tear, a dissection, or the vessel still collapses, that's when you bring in a stent.
That's the classic indication for stenting. Yeah. For the SFA, we use these specialized, flexible, self-expanding nitinol stents. They act as a scaffold to salvage the procedure and ensure you get immediate flow.
What if the problem isn't soft plaque or recoil, but just rock-hard calcium? You can't just push that aside.
You can't. That's the domain of plaque modification. We often start with atherectomy.
And that's physically removing the plaque.
It is. These are specialized catheters that can shave, cut, or drill through the hardened plaque. But importantly, atherectomy is usually used to prep the vessel. The goal is to make the lesion pliable enough so that your next therapy...
So it breaks the armor without harming the vessel wall itself?
Exactly. This lets you then inflate a balloon or deploy a stent at a low pressure, getting full expansion without the high risk of dissection or rupture. It's especially useful in the common femoral artery, the CFA, which is a critical junction point.
Okay, let's go all the way down to the most challenging area, the tibial runoff, the desert foot. The vessels are tiny and desperately needed.
For CLTI salvage in this severe discal territory, we have to use ultra-specialized techniques like pedal loop reconstruction.
What does that involve?
It often requires accessing vessels way down on the foot, sometimes going retrograde, threading a wire up from the ankle. The goal is complex.
Yeah.
You're trying to reestablish flow to the microcirculation right around the wound, often by linking up the few remaining tiny vessels to create a functional loop.
So that's the high-tech side. Let's contrast that with open surgical revascularization. When do you just say, forget the wires, we need a bypass?
We choose surgery when the anatomy is just too complex for a durable endovascular fix. The principle is, when anatomy is long segment, heavily calcified, or reintervention high surgery, wins patency.
You accept more upfront risk for a better long-term result.
Exactly. You accept the higher trauma because the benefit is dramatically improved long-term durability.
Give us the numbers. For that complex inflow correction, the aortobifemoral bypass.
It's a major open abdominal surgery, but the results are just phenomenal. You see patency rates of 80–90% at 5 years.
Wow.
That is just unmatched by any endovascular option for that kind of extensive disease. It's still the gold standard if the patient is fit for it.
And moving down to the FemPop segment, you mentioned location and material really matter here.
They do. For bypasses that stay above the knee, where the vessel is larger and moves less, synthetic grafts like PTFE are generally acceptable.
But once you cross that knee joint,
Everything changes. The biomechanical stress and smaller vessel means synthetic grafts fail very quickly. So for any bypass that goes below the knee, the great saphenous vein, GSV, is the gold standard.
using the patient's own vein.
It's the best biological conduit we have. The patency rate here using the GSV is typically 70–80% at 3 years. That superiority is why a good GSV is a vascular surgeon's most prized resource.
And for the most dire CLTI cases, those distal pedal bypasses, you must have to use vein there too.
Absolutely. These are highly technical procedures for true limb salvage, and they require the absolute best conduit. That means using the GSV, or if that's gone, using arm vein.
Before we move on, let's touch on the hybrid approach. This is where you blend the best of both worlds.
The hybrid approach is often for multi-level disease, and the classic example involves the common femoral artery, the CFA.
That big junction in the groin.
Right, and open surgery gives you the most durable fix there. We call it the brancher strategy. The surgeon does an open CFA endarterectomy, physically opens it, scrapes out the plaque, and sews on a patch.
So you fix that critical junction with open surgery first.
Correct. And once that's fixed, from that same incision, you can then immediately access the SFA and deploy your endovascular tool stenting, DCB, whatever you need, for the downstream part. It's a really powerful strategy.
All done in one sitting in a specialized hybrid suite.
Exactly. It combines the gold standard durability of open CFA repair with the minimal invasiveness of endovascular SFA treatment. Best of both worlds.
This brings us to section 3, the decision matrix. This is where all that MCH training comes together, right? Synthesizing the anatomy, the data, patient factors. How does a surgeon navigate that choice between endo speed and open durability?
This is where we tie the anatomical scores, like GIAS, to the predicted outcomes, the patency rates. It's a tailored calculation of risk versus benefit for each patient.
Okay, let's look at the critical scenarios. We mentioned multi-level disease, blockages everywhere. How do you tackle that?
Multi-level disease is a strong argument for the hybrid approach. For example, you treat the iliacs endovascularly to get your inflow pressure up.
Minimally invasive.
Right, and then you immediately follow that with an open FemPop or distal bypass. This saves the big, durable open operation for the segments that need it most, usually the long distal ones.
What about the other extreme? Severe tibial disease. We know those tiny vessels are a nightmare.
They are. And in that scenario, the preference tilts away from general endo and moves strongly toward either those specialized pedal endovascular techniques like the loose we talked about, or a surgical bypass using the vein. The critical nature of CLTI demands the most reliable flow you can get to that wound. If you have a good vein, the superior durability of a bypass in that tiny, turbulent environment makes it a very attractive option.
Okay, now here's a critical one that's tied to durability. The patient's age. A young patient with a long SFA occlusion, a TAS-UD lesion. Why does being young push the decision toward open surgery?
Because the surgeon is thinking in decades, not just a few years. A TAS-D lesion is a long occlusion, often over 25 centimeters. We can stent that.
But should you?
Well, the patency data shows the failure rate is significantly higher. It often drops below 50% at 3 years.
So a 40-year-old would just keep coming back for reinterventions every few years.
Precisely. Multiple procedures, multiple anesthetics, and each fix is harder than the last. A well-done vein bypass, though, offers that 70–80% patency at 3 years. and it holds up much better over the long term.
So the initial big surgery is justified by the promise of lasting success.
For a patient with decades of life ahead, yes.
So conversely, when is endovascular basically mandatory, even if the anatomy screams for an open fix?
When the patient has what we call hostile anatomy, this is typically an elderly, frail patient who's had multiple prior abdominal surgeries, has dense scarring, or a heavily calcified aorta you just can't clamp.
So an open bypass is just too dangerous.
Unacceptably high risk of mortality. The priority shifts to survival, so endovascular, even if it's less durable, becomes mandatory to restore flow with minimal trauma.
And this brings us back to what you call the vein rule.
This rule is the synthesis of all of this. It's simple. If the patient has a good vein, GSV, and their life expectancy is greater than 2 years, surgical bypass is strongly considered.
But if they're very frail, life expectancy of a few months.
Then the trauma of a major open surgery isn't ethically or medically justified just for the sake of 5-year patency. You're weighing the acute risks of the operation against the superior long-term patency curve of the vein.
It's personalized prognostication.
It is a cold, hard statistical weighing of risk versus reward.
Let's talk about some of the advanced materials. How have technologies like heparin-bonded ePTFE grafts improved things for open surgery?
Standard ePTFE grafts, especially in long bypasses, have a significant risk of clotting. They're thrombogenic. By chemically bonding heparin, an anticoagulant, to the graft surface, the material becomes much less likely to form a clot.
And this improves the outcomes.
The source material notes these grafts significantly improve patency, especially when you don't have a good vein available for a long bypass. It's an attempt to bridge that performance gap between synthetic and natural vein.
And finally, let's address the controversy around paclitaxel-coated devices, the DCBs and drug-eluting stents. Where do we stand on those now?
The controversy started with some initial meta-analyses suggesting a possible delayed increase in mortality linked to the drug paclitaxel.
That's obviously a huge concern.
It was, but subsequent larger data sets have offered a lot of reassurance and suggested that signal was likely overstated or maybe related to other patient factors.
So are they still being used?
Absolutely. They are still recognized for their essential, proven benefit in improving patency, especially in the SFA. The difference now is that their use requires meticulous informed consent.
Meaning you have to spell out the history.
You have to explicitly discuss that theoretical long-term risk with the patient. They have to understand the trade-off. Superior patency now, balanced against that historical mortality signal. They remain indispensable tools.
We're moving now into 2 high-pressure scenarios that really test a surgeon's judgment and speed. First, the incredibly difficult situation of the no-option limb.
Yeah, the commitment to saving a limb is paramount. And the source material defines the criteria for attempting salvage with a remarkably low bar. It says, salvage if there is even a single straight line flow to the foot.
Just one patent vessel to the foot. That means the surgeon will pursue a repair until the absolute last possibility is exhausted.
Correct. That single line, however tiny, is a potential conduit to heal a wound. The focus isn't just on patency, but on achieving any perfusion that can relieve that rest pain and prevent amputation.
But sometimes that's just not possible.
Sometimes the anatomy is just non-reconstructible.
And in those cases, what can you do for the pain? That ischemic rest pain is supposed to be excruciating.
It's unbearable. In these cases, we look at pain modulation. Spinal cord stimulation is one option. You implant a device that sends mild electrical pulses to the spinal cord to modulate the pain signals before they reach the brain.
So it's palliative, a quality-of-life intervention.
Primarily.
And what about trying to biologically regenerate the flow you can't surgically fix?
That's the realm of cell-based therapies. These are strictly experimental right now in trial settings. They often involve injecting the patient's own stem cells into the ischemic muscle.
Hoping to grow new blood vessels.
The hope is to stimulate angiogenesis, to naturally revascularize the tissue. It's promising in concept, but it's not yet a proven, reliable replacement for reconstruction.
So if you've hit the anatomical wall and pain management isn't enough, you reach that agonizing decision. Amputation. What are the criteria for declaring a limb non-salvageable?
This is the moment of greatest consequence, and it rests on 3 main criteria. First, non-salvageable infection.
So if the infection is out of control.
If you have rapidly progressing gangrene or sepsis that you can't contain, amputation becomes a life-saving measure. The infection threat outweighs the limb salvage attempt.
Okay, what's the second reason?
Non-reconstructible anatomy. This goes back to the GLAS score. This is the patient with such diffused, severe disease that there's simply no viable artery left to bypass to. There's no plumbing left to fix.
And the third ties back to that systemic survival component we started with.
That's when the patient is deemed unfit for revascularization. This is the critically ill patient whose body is so weak, they're unlikely to survive the lengthy open surgery required to save the limb.
So in that case, amputation is actually the safer option.
It may be the safer, more compassionate course to prevent death from surgical stress. It's incredibly heavy calculation.
Okay, let's shift gears to the second critical scenario. The acute on chronic presentation. This is a true vascular emergency, isn't it?
This is the race against time. Every minute means irreversible muscle and nerve death. The rule is absolute. Do not delay revascularization. You have to restore perfusion immediately. We say time is muscle.
So what's the immediate action plan? What's the first call?
First, urgent imaging. Non-negotiable, usually an urgent CTA or a DSA. We have to see the exact location of the acute clot and the underlying chronic problem that caused it.
And then you go in to get the clot out, the thrombectomy.
Intervention has to happen within hours. We can use a surgical Fogarty balloon catheter, go in, inflate it past the clot, and pull it out mechanically. Or we can use advanced catheter-based thrombectomy devices that, suck the clot out.
But if you just remove the clot, it'll just reform, right? Because of the underlying blockage.
That's the crucial point of acute on chronic. Once the acute clot is out, you must immediately perform the secondary angioplasty or bypass to fix the underlying chronic plaque. You have to fix the source of the problem right then and there.
And finally, there's a dangerous complication after you restore flow, reperfusion injury.
Yes, this is often overlooked but can be devastating. Compartment syndrome.
What happens?
When a limb has been ischemic for hours, the cells are damaged. When blood flow returns, it causes massive swelling inside the rigid compartments of the leg.
And that swelling can crush the nerves and muscles.
It can, leading to irreversible damage even if the blood flow is perfect. So the surgeon must consider fasciotomy, surgically opening those compartments to relieve the pressure. It's a key part of the post-revascularization checklist.
We've navigated the strategy, saved the limb, managed the acute risks. Now, Section 5. Long-term success. The battle to restore flow turns into a lifelong commitment to surveillance and medical management.
Maintaining patency, keeping that bypass or stent open, is a critical ongoing task. If the reconstruction fails, the patient is at a very high risk of amputation, so active surveillance is mandatory.
What's the established schedule for that surveillance?
It relies heavily on non-invasive imaging, specifically duplex scans. The schedule is clustered at the beginning, at 1 month, 6 months, and 12 months post-op, and then annually after that.
Why so frequently in that first year?
Because that's the highest risk period for failure, largely due to that neo-intimal hyperplasia we talked about.
So you're looking for a narrowing again?
You're looking for a developing stenosis, a silent narrowing, before it becomes a complete acute blockage. If you catch it early, you can often do a simple, quick endovascular revision and preserve the main reconstruction.
And this surveillance has to be paired with that unbreakable commitment to medical management. Just to confirm, the duration for DAPT.
For most stenting, it's a minimum of at least 3 to 6 months. That covers the critical healing period. But for complex bypasses or high-risk patients, it could be extended indefinitely.
And statins. Is that commitment truly lifelong?
Yes. Statins are a lifelong commitment because you're treating systemic atherosclerosis, not just a cholesterol number. The main benefit is plaque stabilization and reducing cardiovascular events. Stopping the statin removes that protection.
And finally, for those patients who successfully had their CLTI reversed, what specialized follow-up do they need?
The limb is never truly safe because these patients usually have sensory neuropathy. They can't feel pressure points or injuries. They need routine, mandatory follow-up in dedicated foot protection clinics.
What happens in those clinics?
They manage that triad of risk: ischemia, neuropathy, and infection. The staff ensures proper footwear, checks for subtle ulcers, provides meticulous wound care. It's essential because the highest risk for a future amputation is often a new, unrecognized wound. It's the final line of defense.
We have covered an incredible depth of strategy today. Let's bring it all back to that philosophical summary, the MCA-style summary line that guides this whole process.
The strategy can really be synthesized into 3 clear priorities: optimize survival, rescue limb, maintain patency.
And that order is critical.
It's crucial. Survival first, through aggressive medical management, then the immediate precise rescue of the limb, and then the long-term commitment to keeping that fix open.
And the decision on how to do that rescue is dictated by those classification systems we started with.
Absolutely. The decision is guided by two balanced factors: anatomic complexity, GLS, which tells you what's feasible and durable, and clinical urgency, WAFI, which sets your timeline.
And the ultimate takeaway on the choice between endo and open.
I think the field is driven by an endovascular first for most mentality. It's less invasive, recovery is faster, but the fundamental truth remains. Vein bypass is unmatched for distal disease durability.
Still the gold standard.
When long-term success is critical in those tiny turbulent vessels of the lower leg, the great saphenous vein is still the one thing that no tech can truly replace.
This has been a compelling look into the high-stakes, multi-layered thinking required to manage chronic limb threat. It really is strategic warfare against a systemic disease.
Before we close, here's a provocative thought for you to carry forward, building on our discussion of the no-option limb.
Okay.
As our global population ages and the prevalence of diabetes and cardiovascular disease increases, the number of patients presenting with this complex, diffuse, non-reconstructible anatomy is only going to grow.
So we're going to be hitting that non-reconstructible wall far more often.
Exactly. Given that our current standards still hit a wall when there's no viable artery or vein left, what's the future role of those experimental therapies?
Like the cell-based therapies.
Right. If cell-based therapies, or maybe even genetic therapies, eventually become reliable, allowing us to biologically regenerate the necessary runoff in that desert foot, could that technology entirely push the concept of the non-salvageable limb out of modern practice?
That would be a monumental shift.
It wouldn't just save millions of limbs. It would fundamentally transform the enormous healthcare economics currently dominated by amputation care. It's the critical biological challenge facing the next generation.
A fascinating and optimistic thought for the future of this high-stakes field. Thank you for joining us on this deep dive. We hope you feel thoroughly informed on the advanced strategies used to decode and manage chronic limb threat. We'll see you next time.